Welcome back. In today's episode, we're diving into the pharmacokinetics and bactericidal mechanism of Cefixime, a third-generation cephalosporin antibiotic. We'll explore how the drug is absorbed, distributed, metabolized, and excreted, and what actually happens inside bacterial cells that makes Cefixime so effective. Let's start with how Cefixime actually kills bacteria. Cefixime inhibits bacterial cell wall synthesis, meaning it stops the bacteria from building the protective wall that gives it shape and structure. When this wall-building process stops, the bacteria become weak and unstable. Now, here's the interesting part. Bacteria actually have their own self-destruct enzymes called autolysins and murine hydrolases. These enzymes normally help remodel the bacterial wall. But when Cefixime blocks cell wall assembly, these enzymes keep breaking down the wall without being replaced, eventually causing the bacteria to burst apart. Did you know that some antibiotics rely on the bacteria's own enzymes to finish the killing job? Pretty smart chemistry, right? Now let's talk about pharmacokinetics, starting with absorption. When Cefixime is taken orally, its absorption is about 40 to 50%, meaning roughly half of the dose actually makes it into the bloodstream. Now, here's a key point. Not all formulations are equal. Chewable tablets and oral suspensions are considered bioequivalent, which means they deliver the same drug exposure. But capsules are not bioequivalent to suspensions. Also, taking Cefixime capsules with food can reduce the total exposure, which is the area under the curve, by about 15% and the peak concentration by around 25%. So, for maximum absorption, it's often better to take it on an empty stomach. Once in the bloodstream, Cefixime distributes widely throughout the body. It reaches therapeutic concentrations in most tissues and body fluids, including synovial fluid around joints, pericardial and pleural fluids around the heart and lungs, peritoneal fluid in the abdomen, as well as bile, sputum, urine, bone, myocardium, gallbladder, and skin and soft tissue. About 65% of Cefixime binds to plasma proteins, meaning some is free and active, while the rest is temporarily stored in circulation. Cefixime's half-life, that's the time it takes for half the drug to be removed from the body, is about 3 to 4 hours in adults with normal kidney function. In moderate renal impairment, it increases to about 6.4 hours, and in severe renal failure, it can go up to 11.5 hours. That's why dose adjustment is important in patients with kidney disease. Cefixime is mainly eliminated in the urine. About 50% of the absorbed dose leaves as active drug. The rest, around 10%, exits through the feces. Cefixime's bacteriostatic and bactericidal effect depends on time, not concentration, and therefore, like all cephalosporins, it's known as a time-dependent antibiotic. It needs to keep its free, unbound concentration above the minimum inhibitory concentration, MIC, for a certain percentage of the dosing interval to be effective. So for Cefixime, increasing the dose doesn't necessarily make it work better if the drug level still drops below MIC too soon. Cefixime also has a post-antibiotic effect, a short period, generally less than 1 hour, during which bacterial growth stays suppressed even after drug levels fall below MIC. Can you guess which antibiotics rely on concentration instead of time for killing? Mention it in the comments below. Understanding these pharmacokinetic and pharmacodynamic principles isn't just about numbers. It's what ensures correct dosing, effective treatment, and reduced resistance. If you found this breakdown helpful, don't forget to like, subscribe, and turn on notifications for more clear and engaging pharmacology lessons every week.